actually is traveling,
Yes, sir.
so it's uploading to YouTube.
Good evening, everyone.
Good evening.
Good evening, sir.
Good evening, sir.
Good evening, Rajgopal.
Good evening, Dr.
Good evening,
Sudesh.
sir.
Good evening.
Director
Good evening,
Pratap.
sir. Good evening.
Yeah, and all panelists. I can see Birappa, sir.
Good evening, sir.
Yeah.
You-
Mishra,
ಚೆನ್ನಾಗಿದ್ದೀರಾ?
P. Mishra,
You're already
all my class.
you're already live, Gaddi.
Good.
Yes, sir.
Right.
Good
Carry
evening,
on.
sir. We are live now on YouTube. So, good evening, everybody. Welcome to ASI Time. This is the first week of the month. We have case capsule, the abdominal surprises. To this meeting, I welcome President ASI Dr. Maruthu Pandyan. I also welcome Vice President Dr. Pratap Sinha Varute, our Academic Council Director Dr. Rajgopal Shanai, Convener of International Affairs Dr. Probal Niyogi, the Social Welfare Director Dr. G. Siddesh, and Moderator Dr. N. Birappa and his panelists including Dr. Parikshit Malhotra, Dr. Ankur Maheshwari, Dr. Ban Bihari Mishra, and Dr. Srishail Madegood. I request President to make the initial remarks before we proceed to the program.
Good evening, all. Respected the principal office bearers, Dr. Pratap, Dr. Gaddi Divakar, Madhubeda ma'am, Dr. Prabal, Dr. Siddesh, and Academic Director Rajgopal Shanai, and all the panelists, including our moderator, Dr. Birappa. First of all, my sincere thanks to the moderator and the panelists for having participating in this program. I came to know through the academic director that we are going to have two interesting cases. One is diaphragmatic hernia and another one is, I think, paraesophageal hernia. Is it, sir? So diaphragmatic hernia, really it is an interesting topic to be discussed. I had one experience with that management of diaphragmatic hernia. 15 years ago, I did on left-sided diaphragmatic hernia thoracoscopically. But after 15 years, we had recurrence, and 2 months back only we did it laparoscopically from this side. But of course, patient is fine and doing well. I just want to share that my experience on that diaphragmatic hernia. With these few words, I request our Gadi Divakar sir to proceed further.
Yeah, I also welcome our honorable treasurer, Dr. Madhumita Mukhopadhyay, to this meeting. Now I request our Vice President, Dr. Pratap Varute, sir, to make some comments.
Thank you very much, Dr. Gaddi. Respected President ASI, Dr. Murtha Pandyan. Immediate past President, Dr. Praveen Suryavanshi. Honorary Secretary, Dr. Gaddi Divakar. Honorary Treasurer, Dr. Madhumita Mukhopadhyay. Director Academic Council, Professor Dr. Rajgopal Shanai, sir. Convener International Affairs, past President ASI, Dr. Prabal Neogi, sir. Director Social Welfare Council, past President ASI, Dr. G. Siddesh, sir. And the Principal Architect of the ASI Academics, past President ASI, respected Dr. Santosh John Abraham, sir. It gives me immense pleasure to welcome all the eminent panelists for this interesting case capsule discussion on abdominal surprises. Dr. Parikshit Malhotra from Mandi, Dr. Ban Bihari Mishra from Cuttack, Dr. Ankur Maheshwari from Indore, and Dr. Srishail Madegood from Belgavi. And to add more delight to this entire program, we are honored by the gracious presence of the veteran teacher, Dr. Birappa sir, from Hyderabad to moderate the entire session. Today's case capsule discussion will surely be very interesting considering the entire surgical fraternity all over India. And as we come across these surgical abdominal surprises in our day-to-day practice, we often label abdomen as a Pandora's box, where the preoperative imaging and clinical signs may point to one thing, but the moment you enter the peritoneal cavity, something entirely unexpected comes in your front. Today's case capsule carries the same ethos. So I'm sure that today's case scenarios will be extremely interesting for the entire viewers on the ASI YouTube channel. I wish all the very best for the entire panel for the wonderful hour ahead. Thank you very much.
Thank you, sir. Dr. Prabal, sir, quick comments from you, please.
A very good evening to all. Respected President ASI Dr. Pandyan, Vice President Dr. Pratap, Secretary Gaddi, Treasurer Madhumita, uh, Director Academics Raj Gopal sir, and Director Social Service Siddesh, and the very learned panelists headed by Dr. Birappa. It gives me immense pleasure to be part of this ASI program, which incidentally I started about a couple of years ago during my presidency, that is in 2024. And I'm so happy to see it flourish under the leadership of my successors. And Dr. Maruthu Pandyan, Dr. Pratap have taken it to a new level. They have added more color to it. And I'm so thankful to you because this is one time that we needed. The association needed for teaching, for getting our thoughts across. Then we have lateral talks as well. So I'm so happy to see this flourish. And my best wishes to all of you for a very interesting case series. Though the president sir has let the cat out of the bag, but nevertheless we will be witnessing some interesting academic discussions on this. Thank you very much, and my best wishes to all of you.
Thank you, sir. Over to Dr. Raj Gopal Shanai, sir, our Director of Academics.
Thank you very much, Dr. Diwakar Geddi. With the respect to President Dr. Maruthu Pandyan and entire top leadership, without wasting much time, it's a welcome each one of you for this wonderful session, which we had started in March, and this is the third case capsule. So, and these are all interesting ones. They are watched by more than 1,000, 1,200, 500 viewers. So please make use of this interesting topics. And without wasting much time, Dr. N. Birappa, Director of NIMS, Hyderabad, one of the most eminent personalities, and is actually a very, very busy person with a lot of responsibilities. In spite of that, sir, you have agreed to moderate this wonderful session, and excellent four panelists are there whom you are going to introduce them. And I request each one of you, especially these are helpful for postgraduates, helpful for practicing surgeons, and always remember, every time suddenly there may be some guidelines, there can be some standard protocol, but you may not be in that position to have your instruments with you. It may come a sudden emergency. Most importantly, there's a saying called a proof of the pudding lies in eating. The results are important. Our patient should be able to walk home with the minimal accepted, that morbidity or whatever it is. So with these few comments, I would request Dr. N. Birappa to take over, and probably you can go ahead with the proceedings.
Thank you, sir. Thank you. Good evening, everyone. It's my pleasure to be here today with ASI, what do you call as body.
Yeah. Okay.
And first, let me thank Raj Gopal Shanai for giving me this opportunity. So I accepted this in spite of my very, very, very busy schedule. I don't know when I get a call from government, but still, I love teaching. Thank you very much, sir, and thank you, the President Maruthu Pandyan, Varute, and Suryavamshi, Gaddi Diwakar, Madhumati Madam, Raj Gopal Shanai, and others. Thanks for giving me this opportunity. And I'm just going to introduce this Mishra from Cuttack, Maheshwari from Indore, and Metgood from Karnataka. So I'm Dr. Birappa. Let me start with one case, first case. Here we have a 60-year lady coming to the hospital with symptoms of pain in the abdomen and vomiting since 1 year, on and off. mainly food particles, and there's no blood, no bile, and she was feared to consume food, and worsening of the symptoms since 10 days, some fullness in the upper abdomen, and also she complains of retrosternal burning. She's been taking proton pump inhibitors as suggested by the doctors, and she's a known hypothyroid since 20 years on Eltraxin, 75 micrograms per day. She's hypertensive and she's a diabetic since 10 years. So, with this history, I'd like to know from the panelists. Anybody can answer. Anybody can say that what kind of probably diagnosis we are hinting at. So, shall I start with Malhotra ji?
Yes, sir. Keeping this history in mind, I'll keep the possibility that the patient might be having peptic ulcer disease, a chronic duodenal ulcer with probably gastric outlet obstruction developing. One,
Okay.
the other thing can be cholelithiasis, because
Yeah.
the patient is also hypothyroid, and people with hypothyroidism, as we know, are more prone to developing gallstones, and this may be because of the gallstone disease as well.
Yeah. Would you like consider any medical problems, Dr. Mishra ji? Dr. Mishra ji or Dr. Maheshwari?
Sir, Mishra ji, unmute yourself, sir.
Yes,
Yeah,
yes,
okay.
yes. Sir, with this frank history, I'll put the diagnosis as a case of gastric outlet obstruction at the beginning, whether it is a intrinsic or
Consider gastric outlet obstruction. She never had any kind of, typical peptic ulcer symptoms. She had only pain and vomiting since 1 year, but it was never like classical peptic ulcer symptoms. Will you still consider a gastric outlet and a lady of 68 years? And so, would you consider still peptic ulcer, sir, and gastric outlet obstruction? Why can't we just consider medical problems like gastroparesis because patient is hypothyroid, patient is diabetic, and why can't we consider just functional dyspepsia or cyclical vomiting syndrome, something like this? Anyone?
One thing is for sure, sir.
Ah,
She has some amount of or some features of a motility disorder. So
yeah.
probably would be thinking on those lines. And
Mhm,
that motility disorder has worsened over the last 10 days or so, but
mhm.
the symptoms were for a longer time.
Yeah,
So that is one fundamental point in the history which is coming.
yeah,
Hypothyroids also have a penchant for a motility disorder.
yeah.
So
Hypothyroid
apart
and
from with
diabetic.
hypothyroid and diabetic, so
Yeah.
functional disorder or motility disorder will come into the mind.
Yes. Yes. Any other possibilities? I understand we should consider gallbladder stones because elderly lady. We should also consider peptic ulcer disease. We should also consider, I think, functional disease also most important. Gastroparesis also most important. We should consider based on the history I'm talking about. Any other
Can,
possibilities? Yeah,
can we
please.
consider gastroesophageal reflux disease, sir, in this? Vomiting?
Yes, that's what. Any patient, elderly with the diabetes and hypertension, hypothyroid, we can consider, but they'll have more of a retrosternal burning. Probably that's
Yes,
why she must
that
have
is not good.
responded. Yeah. So,
but this patient has frank vomiting with food particles. So we
yes,
have
food
to address that
particles.
properly.
So, food particles. So, definitely peptic ulcer, gastric outlet obstruction, and there is no history of loss of weight and appetite. So, we cannot consider
Yeah.
this is basically a benign problem, not a malignant problem. So we may consider a functional problems as well as a peptic ulcer disease or gallbladder stones, gastric outlet syndrome. Well, with this specific diagnosis, and she was examined, her vitals are normal, and she has a vague mass in the epigastric region, which is a tender, and there is no free fluid, and bowel sounds are present. Now, would you like to revise your diagnosis? Vague mass palpable in the epigastric region and tender in elderly lady. Would you consider a malignancy at this stage at least?
Sir, the possibility cannot be excluded, but in the presence of a gastric outlet obstruction, unless the stomach is decompressed, we can sometimes get a palpable, ill-defined palpable mass, which will be
Yes.
resonant on percussion. Second
Yes.
possibility, if at all there is a possibility of pancreatitis pain, which she might have not told clearly, on the
Yeah.
development of cyst, but to me, with this gastric outlet obstruction, probably it is just a distended stomach.
Yeah. Yes. So, any other investigations, any other diagnosis? Malhotra ji, Maheshwar, Metgood. Metgood, would you like to add anything?
So can we consider the possibility of any mass arising from the left lobe of the liver,
Like,
like
yeah,
cystic lesions? Can we consider, sir?
you mean to say is, but she has any liver lesions doesn't cause any vomiting.
Yeah, they don't cause
Liver,
vomiting.
yeah, liver lesions doesn't press stomach unless it's in a huge leiomyoma, leiomyosarcoma, something very rarely comes from the liver which compresses the stomach. But any liver lesions doesn't cause vomiting unless patient has an CS stomach with liver metastasis. But usually 99% liver lesions doesn't cause vomiting. They may have a pain, dull aching pain, and symptoms of cystic lesions can have a dull aching pain, nothing more than that. They are most of the times they are asymptomatic. So any vague mass palpable in the epigastric region, we may not be able to connect to the GA symptoms. So she has any GA symptoms, I definitely consider a distended stomach. Since she has an vomiting and pain, so peptic ulcer disease, distended stomach, and is also possible. Tender sometimes, yes, distended stomachs are tender.
It,
So
it may be a complicated gist as well, sir, which may have caused the pain, the sudden increase in pain of late.
GIST, gastrointestinal stromal tumors, again, the main presentation is, of course, mass and GA bleed. So they'll have a gastrointestinal bleed, but this patient they never had a GA bleed. They'll have a mass, and they don't present with any pressure symptoms. They don't present with an intestinal obstruction. They will have a huge mass, gastric mass, but still the symptoms are very less. So I do not consider GIST of the stomach, but I consider probably in a distended stomach. Let's see what investigations. Of course, systemic examination is normal, and chest is normal, normal vesicular breath sounds, and reduced on the right side. So breath sounds are reduced on the right side, and nothing other than that. Systemic examination is normal. So what investigations? And she had severe pain 2 days back, and some breathlessness, for which some X-ray was taken and patient was referred. So how to proceed about this patient? An elderly lady, 68-year lady, on and off pain and vomiting now, some breathlessness and some pain in the abdomen. And how do you investigate this kind of patients? Malhotra ji? Anybody can take up, no issues.
Maybe we'll start with a chest X-ray and an ultrasound of the abdomen.
Ultrasound of the abdomen, right? Yeah. And say our clinical diagnosis is now probably a gastric outlet obstruction. That's the first possibility. If that is the case, I definitely will not ask ultrasound of the abdomen. That may not be a good investigation. Rather, I'll put in a Riles tube into the stomach and check what kind of an aspirate it is. If it is only food material and all, probably I do directly go for after emptying the stomach. After emptying the stomach, I may go for an endoscopy. But here is the patient who has long pain and vomiting. So, what kind of an investigation? Ultrasound may show, okay, distended stomach, no other findings. Would you go?
I
Would you like
think
to do?
in this
Yeah.
patient, we
Yeah.
have to look to the patient from three angles.
Yes.
There is chronicity, there is
Yes.
acute exertion, there is
Correct.
vomiting, as well
Correct.
as there is respiratory symptom. So
Yes.
everything mixed together, it's a gastric outlet obstruction. There is
Mm.
some amount of respiratory problem, and there
Mm.
is probably a palpable stomach, distended palpable stomach. So my
Yes.
approach will be to
Mm.
first at the outset before decompression, I will try to take a X-ray of the abdomen, X-ray of the chest. Ultrasound may not be very effective before the Riles tube insertion. After the nasogastric decompression, I will go for a ultrasound, see all these things, and proceed further.
Yeah. Yeah. Maheshwari, you have
Yeah.
anything?
So I will concur with Mishra sir. A basic ultrasound and then further more investigations would be the pertinent thing.
Mm-hmm. Mm. Okay.
Yeah.
So, yeah. The
So,
now X-ray has been taken. Yeah, please go ahead.
no, sir. In such a patient like this, I think one more important investigation would be an ECG, sir, with 2 days history of breathlessness and
Yes.
elderly lady. We'll have to
Definitely.
rule out any cardiac issues. So
Yes.
ECG would be mandatory, I feel, sir.
Yes. You
Certainly,
are
sir.
correct. Rightly said. And in the background of diabetes and hypertension, definitely we'd like to rule out medical problems also, cardiac
The
issues.
ECG will be important from two good points. Number one, to rule out the cardiac condition. Number two, also as a routine before doing endoscopy in an elderly patient, that will guide you.
Yeah, correct. I think one precaution very important is directly one should not go to the endoscopy in this kind of patients because the distended stomach, sometimes they may aspirate. So we have to completely empty the stomach and then go for an endoscopy if at all, if necessary. However, as you said, X-ray the abdomen or X-ray the chest and then followed by an ultrasound would be useful because we would like to do always non-invasive test first done before going for an invasive. So this is the X-ray taken and this is the chest X-ray. Someone wants to comment? Yeah, Malhotraji or Mishra, Maheshwari, Petgood, whoever it is.
If I look at this X-ray,
Mm.
because the patient has its apex on the left, and
Mm.
I see that there is a part of the gut which is in the right chest, and
Mm.
this is the mucosal pattern is not clearly visible, not mimicking the small intestine, not to the large intestine. I
Mm.
presume that
Mm.
this is still a part of the stomach with distension with liquid as well as
Yeah.
the gas. So
Yeah.
this is a very clear-cut thing that without any doubt, even though it may be rare, one can say that is this is the presence of the stomach in the right chest.
Yes.
And rest of the lung parenchyma looks normal, excepting little bit changes in the lower zone.
Okay. Anything else, sir? Anybody would like to
There,
add?
there
Medgood.
seems the gas shadow cell, the stomach shadows appears to have obscured the part of the heart cell. The cardiac
Mm.
shadow is not totally visible, especially the right side.
Yes.
So it is likely that
Yes.
it is in front of the cardiac shadow. Possibility
Mhm.
of something herniating has to be kept in mind, sir. That is one classical shadow which comes obscures the heart shadow.
Yeah.
Okay. You mean to say it's an eventuation of the diaphragm?
It's it doesn't look like an eventration, sir, but I
And the
wouldn't
right side
I
eventuation is
wouldn't
angle.
call it as an eventration, sir. Probably it is not an eventration, sir.
Yeah. And right side eventuation is very uncommon. So as I said, any other things?
Now, once it is a eventration, the radiology picture of the chest will be totally different. Now, if you see in this film, only the part that looks like the stomach has gone in, but in a eventration, the
Yes.
diaphragm outline will be very clear in the chest cavity.
Yes. Correct. So how do we proceed? What next? Would you like to do barium or endoscopy or CT scan? That's how we ask in the examination postgraduates.
Yes, so we can do a water soluble contrast examination. fluoroscopy.
You mean to say barium swallow? Or you want
Yes,
to go for a CT scan, chest and abdomen?
so CT scan has certain advantages over the. It is fast. It will give you additional information regarding other pathologies in the abdomen, or if there is a herniation, it will tell about the size, the organ that is herniated into the. So that are the advantages. So depending if the renal functions are fine, we can straight away go with a CT scan.
Yeah, correct.
The common,
Yes, sir.
for a CT scan would be a wise choice, sir, because that
Yeah.
will give a view of chest as well as abdomen as well as the part connecting both of them, the diaphragm.
Yeah.
Because whatever pathology is there, it is there in the right hemithorax. And you can see a air fluid level there. For a common person, a right hemithorax with the air fluid level always will go for a CT scan chest and abdomen, and that is a pertinent choice rather than going for any soluble contrast investigation if it is available.
So I
Okay. Is
think
it
to
role
this
for?
patient, I
Yeah.
think that to this patient, we must subject the patient for a good hematological, biochemical parameters. And also, we must look at the respiratory test in terms of the oxygen saturation and everything, even though the radiological picture is not very bad. After that, all the parameters, we will decompress the stomach fast, then go for both the upper GI endoscopy as well as the CT. I don't feel almost the barium is a obsolete investigation for this. There is no need of water soluble contrast because we are directly go for a CT of the abdomen, which will also cover a part of the chest.
What do you think we need to do an upper GI endoscopy in this patient? Because non-invasive, we can straight away go for a CT scan. Of course, the blood investigations, urea creatinine is normal. What is the need for an upper GI endoscopy? I still maybe still preferring an endoscopy. But do you have any points in favor of doing an endoscopy?
Actually, if at all required, we should go after the CCT because
Not
if
right
we
now.
find, not right now, first the CCT should be done,
Not right
then if
now.
required, we'll go for that. Otherwise, it is not mandatory.
I think the first thing should be we should sort out the anatomy first. And
Yeah.
when anatomy is sorted out, then these investigations should be done.
Okay. So the basic investigations are within normal limits, and this is the sorry. And endoscopy has been done in this patient. I have a reason why endoscopy needs to be done. One is to know the gastric mucosa, number one. Number two, one is to rule out the malignancy if at all present in this age group. So and sometimes they may have medical problems like achalasia, cardia, motility problems. So I think endoscopy is also another investigation we need to do. It's not a mandatory. Once if you know the diagnosis of paraesophageal hernia or a hiatus hernia, it's always better to do an endoscopy and rule out malignancy and Barrett's and other pathologies in the mucosa also. So endoscopy has been done and gastro mucosa could not visualize because of the retained food particles. So and CT has been done. This is the CT. The anybody can read the CT. CT.
I think you can see so the one more sagittal film
Yeah.
because this is just a dilated stomach. The next one it shows that
Mm.
yeah, if you see this first film that is seen, the
Mm.
stomach is dilated.
Mm.
The antrum, pylorus, antrum, and the first part of the duodenum
Mm.
almost they have eventrated and gone to the posterior mediastinum. So
Yeah.
that clinches the diagnosis. And
Mm.
if you see the antrum and the duodenum, they are at a higher level than the gastroesophageal junction. So it
Mm.
probably suggests something about the gastric volvulus. So both the components, the anatomy is well established, and this rotation is also indirectly reflected by the position of the antrum and the duodenum above the GE junction.
Mm.
And the Riles tube is also visible inside.
Yeah, I think I'm expecting that you're going to
Yeah.
comment. Riles to be seen.
Yeah, Riles tube is
So
seen.
it means that riles tube has gone into the abdomen and then into the stomach
But still the
and
stomach is not evacuated,
decompressed.
not
Yes,
decompressed.
yes. So I think what is most important is a level of the G junction. That's most important, whether it's in a above diaphragm or below the diaphragm, in order to classify the paraesophageal hernia or hiatus hernia. So so this is the CT, and the report is stomach is grossly over distended, with the distal part of the body and antrum pylorus and duodenum appear to display supports and are noted herniating into the posterior mediastinum through esophageal itis with subsegmental collapse of the underlying lung. Paraesophageal hernia diagnosed suggestive of with stomach as a content. So there is a displacement of antrum above the G junction. Stomach appears to be upside down with an antrum pylorus, suggestive of gastric valvulus, and there is narrowing at the gastric outlet. That's why patient has a features of gastric outlet obstruction, and nasogastric tube is noted in the stomach. So what next? So elderly lady with all these problems, she has a paraesophageal hernia with the gastric valvulus.
Sir, just one more thing. So can we safely say that the vascularity of the herniated stomach has been maintained looking at the films?
Yeah. I think it's well maintained
Well
because
maintained, sir.
it's well maintained.
So that
Actually,
also
that
is
is a very important point
important.
because you have to decide whether you are going for an emergency surgery or a fully prepared surgery. So that is a
Yes.
very important point. The CT has to decide about the vascularity.
Yes. And there's no any inflammation around the stomach.
Yeah.
And again, it shows that there is no problem with the vascularity. Rest of the intestines are also having good vascularity. So there's no gangrene or mucosal necrosis here. So that indicates valvulus is there, but there's no necrosis or gangrene or any ulcerations. So what should be done next? What next? Now we know that it's an paraesophageal hernia with stomach as a content with features suggestive of valvulus. And we have placed a Riles tube. We are going to definitely decompress and check their electrolytes, and I'm sure that we're going to medically resuscitate her or whatever treatment she needs. We'll do medical, and then take a cardiologist opinion, as one of the panelists said. ECG and then cardiologist consultation is very important. We need to prepare the patient for a surgery. I'm sure the panelists will agree with me.
Yeah.
Yes, sir.
Yes. So, and then what kind of surgery are you planning? How do you plan? Any preoperative evaluation? I said patient needs any cardiac evaluation, but how do you plan? So this is you want to do a
This patient
thoracotomy? Okay.
needs a very good planning. Planning in this
Yeah.
sense, pre-operative preparation is mandatory. We have to keep the ICU ready, good glycemic control, thyroid control, everything is done. Our aim is very clear because once the diagnosis has been made, probably the treatment is very easy. But only thing, we have to go transabdominally, but mind should be open. If required, we may go for a thoracotomy. So accordingly, everything must be ready. And once we do a laparotomy, the next procedure will be decided by seeing the findings only.
Yeah.
Sir,
Yeah, please,
in part of pre-operative evaluation, one important counseling that I would do is that this lady may end up on the ventilator post-operatively, and we need to counsel about that also, sir, apart from all the preparation.
Okay, fine. Because long-standing elderly lady and hypertensive, hypothyroid, maybe yes, we need to take consent for a post-operative ventilator support, and then see that our glycemic control is proper. So, would you agree? Would you prefer a thoracotomy or would you prefer a laparotomy in this patient? Laparotomy or laparoscopy, thoracoscopy, whatever it is. You wanted to approach hernia through a chest or through abdomen. That's the point to be discussed here?
So,
I think in the present era, the first option should be a laparoscopy. Second option is laparotomy if it is okay. Otherwise, mind must be open for laparotomy extended to thoracotomy.
What is the advantage of doing a thoracotomy or thoracoscopic in this kind of patients?
If
In
at
case of
all, many a times it is not reducible, you can take the help.
Okay.
But I think the way it has migrated, it may come out easily. So by opening the abdomen, it can be decided.
Okay. Okay, fine. Anything from Maheshwari, Malhotra ji, Mettigood, anything? Laparotomy or laparoscopy?
the symptoms have worsened in last 10 days, sir.
Ah,
So essentially, whatever's happened has in last 10 days. So
yeah.
I concur that if the contents have to be reduced, they will be reduced quite efficiently from the laparotomy or a laparoscopy incision.
Mm.
The advantage of thoracoscopy or a thoracotomy or perhaps thoracoscopy would be better visualization of the content, and plus if you use carbon dioxide, that creates another important thing where you can reduce it efficiently. So thoracoscopy and laparoscopy are two debatable things, but I would prefer laparoscopy here. That is more pertinent choice.
Yeah.
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 The-
We prefer, yeah, please.
The thoracoscopy can be kept as an option, sir, but looking at the picture and if the stomach is decompressed, I think most of it will come out through the laparoscopy, sir.
Correct.
If we effectively decompress it, it should reduce easily, sir.
Yeah. I'll come back again why sometimes laparoscopy is full again at the end of the discussion. So this patient had a laparotomy, and this case is from Manipal Medical Hospital where Rajgopal Shanai has done surgery. So the operative findings are she has a thickened stomach because of the gastric volvulus and probably repeated pain abdomen, and she must have had repeated volvulus. That's why stomach is thickened, and distal stomach including body, duodenum herniated on the side of the esophagus, and G junction is normal in normal position, and paraesophageal defect is around 4 centimeter with the distal stomach and first part of the duodenum as a content, and there is no evidence of volvulus. Probably the volvulus must have not there at the time of surgery. So she must have had, but CT scan picture shows it's like volvulus only. And at the time of surgery, there's no evidence of volvulus, and the patient also had a colonic diverticle at the same time. So this is I can see the stomach wall thickened, and Professor Rajgopal Shanna has done a laparotomy and he's reduced the contents. And the defect was closed, reduction of the stomach and duodenum, but it was not in a very easy, it seems, maybe because of the thickened stomach, and stomach was viable, and their contents were aspirated. 4 centimeter defect noted in the right side of the esophagus. Defect is sutured by using non-absorbable sutures. Hemodynamically, patient was stable at the end of the procedure. So these are the pictures, and this is the probably this is an area of a big hiatus, and so hiatus was closed, and this is a diagrammatic picture of the operative findings, and very nice to see Professor Rajgopal Shanai, nurses and boys or assistants, and very neat diagram wherein it's showing the first part of the duodenum, antrum, paraphyseal hernia in this patient. So this is how that was then a defect here where it herniated the abdominal contents. So this is then a chest X-ray after surgery. Can see so much of difference. There is not much of stomach is seen in the chest on the right side of the chest, and lungs also clear. Probably these patients needs a post-operative good chest physiotherapy, spirometry in order to prevent the consolidation or atelectasis at the base of the lungs. So anything else would you like to add? What do you think Professor Rajgopal Shana has
Sir,
done
only
correctly, or
one
would you
point.
like to? Yeah, please.
Whenever you decide about the approximation of the defect, it should be a tension-free approximation with a non-observable situation. In situation where there is tension, probably we have to think of the use of a prosthesis.
Yes. Anything else? One is tensionless
Yeah,
closure of the defect. That's most
right.
important, Krura. And if we are able to approximate, fine. If not able to approximate, as I said, absorbable mesh or needs to be placed there. And anything else you would like to add? One is reduction and
Yes.
then closure of the defect. And then anything else would you like to add in this kind of patients? Is there a need for a fund application? That's what I'm expecting from the panelist. Is there
So
a need for a fund?
in
Yeah.
this patient, probably a fundoplication is not required because
Why do you think so,
fundoplication
Babu?
is most of the time reserved for the sliding ones. Here, uh, I do not know. I feel that fundoplication is not required. I don't know what is your viewpoint.
Yeah, I
There
agree
is
with you. It's an individual preference. I'll give my reason. Yeah, Malhotraji, you're
but
saying something.
yeah, there is a school of thought. Some people say that fundoplication also prevents the development of the gastric volvulus. So it prevents it. So some people do it for this purpose. And if there are symptoms of GERD associated with
Yeah.
the paraesophageal hernia, then also people do fundoplication.
Correct. One is to prevent GERD. Second is to prevent recurrence also. Once if you do
Yeah,
fund application, the recurrence of hiatal hernia is less. So that's why I add. In fact, I add fund application, posterior anterior fund application. It's not mandatory always. If you think the hiatus is quite a big and the chances of recurrence are there, and patients had an reflex problem, severe reflex problem, definitely we need to add fund application. However, one should be very careful. We need to sometimes these patients may also need in a manometric studies in order to rule out motility disorders. So if suppose patient has a motility disorders and we reduced and then close the hiatus, they may develop again problems with fund application. They may have a dysphagia. So in spite of having such a big defect, I do not understand why this patient did not have any symptoms of dysphagia. She had only pain and reflex symptoms. So again, so fund application, it's plus minus. As I said, one is to prevent recurrence. Second is to, in a patient who has a severe GERD, then we may have to add fund application. Yeah. Anything else? We'll just go for a small brief review of the diaphragmatic hernia. So they're classified as type. Anything else? I'll just say a few points about the diaphragmatic hernia. Type 1 usually it's in a sliding type wherein G junction is placed above the diaphragm, and paraesophageal hernia, that is type 2 to 4, where defects in the phrenoesophageal membrane allow the migration of stomach and other structures adjacent to the G junction. Sometimes the students will get confused what is hiatal hernia, what is diaphragmatic hernia, what is paraesophageal hernia. So diaphragmatic hernia, this hiatal hernia and paraesophageal comes under diaphragmatic hernia. Hiatus hernia comes as a type 1, usually call it as an sliding one, call it as an hiatus hernia, whereas paraesophageal one hernias are type 2 to type 4, wherein the defect is seen in the phrenoesophageal membrane, which allows the migration of the stomach or other structures adjacent to the G junction. And most uncommon type of hiatal hernia, it affects the adults with the mean age of 65 to 75 years. There are 4 types, as I said. It's the pathophysiology of the hiatal hernia. It's mainly because of increased intra-abdominal pressure that displaces G junction upward into the thorax and esophageal shortening from congenital causes. Here, that's what I said, laparoscopy or thoracoscopy the thoracoscopy or thoracotomy may be useful in places where there is a shortening of the esophagus, and that is the causing hiatus hernia. So we may have to mobilize the esophagus, or we may have to create new esophagus. So that's why thoracoscopy or thoracotomy sometimes may be important. So widening of the hiatus from the congenital or acquired. These are all the pathophysiology of the hiatus hernia. And type 1 is commonly seen, that's in a sliding hernia, wherein the G junction is displaced superiorly into the thoracic cavity. Mostly these patients will have a gastroesophageal reflex. And type 2 is a rolling type. Stomach migrates into the chest and rolls over the esophagus. These patients present with an dysphagia because of the pressure over the esophagus. And type 3 and type 4. Type 4 again, other contents like intra-abdominal contents like colon and duodenum. Type 3 stomach migrates into the chest, rolls over. It's in a mixed actually. So these are the commonly seen. And this is a normal G junction. I just put the slide, squamous columnar junction. So endoscopy is necessary to rule out one, I said malignancy. Second, any Barrett's. So we need to add, if there's any Barrett's is there, the fundoplication. So these are all the types. And the barium, we cannot totally say no for the barium. I feel so. So barium has a role in identifying the level of G junction as well as the content in the paraesophageal hernia. Endoscopy is also important. Sometimes you may see a Cameron's ulcers. That's called as a linear ulcers because of necrosis and other things. And esophageal manometry, I said, to rule out motility disorders. The surgical management, as you everybody said, hernial sac dissection and resection of the sac, esophageal mobilization, if it's possible. One should not be over enthusiastic in mobilization of the esophagus because there might be an injury to the vagus nerve, so which may cause a lot of issues. So repair of the crura and fundoplication plus minus. I prefer to do fundoplication in a case where there is a more G reflex symptoms and G junction is above. So that's brief about surgical management. So some of the learning points are patients younger than 50, even asymptomatic, and older patients with symptoms such as regurgitation, aspiration, cough, anemia. These patients might present with an anemia because of the ulcers which bleed continuously. Our dysphagia should be considered for a surgery. And they may not know that patient has an aspiration, most important, and slowly they will develop in a lung issues. The gold standard of repair in most cases nowadays seems to be laparoscopy. Still, it's an option, surgeon's option, and use of mesh must be selectively to the patient in which crura is unable to tolerate the tension of the primary closure, as Mishra Saab said. And you may have to add in a bariatric surgery if BMI is more than 35.
Yeah.
So that's all about this case. And shall we move on to another case?
Yes, sir.
Yes,
After
sir.
the second case,
Anything
we'll take some
Rajgopal Shanai
questions.
would like to add?
No, sir, nothing at this juncture. We'll go for the Alva. We'll go for the
Yes.
second case. Maybe at the
Yes.
end we can take the questions. Okay.
Yes, sir. This is similar kind of a case capsule. Same panelist. And this young gentleman who presented with abdominal pain, 10 days duration, vomiting since 3 days, and chest pain 2 days. Young gentleman. And insidious onset, progressive in the epigastric region, dull aching, which radiates to back, which has been aggravated after taking food, relieved on vomiting, and multiple episodes of vomiting since 3 days, non-projectile, non-bilious, and which contained food particles. Chest pain, again left-sided, since 2 days. No history of alcohol consumption, no history of cough, breathlessness, no previous surgeries. And he was diagnosed to have an acute pancreatitis based on elevated serum levels. Of course, the pain was typical of epigastric region, which was radiating, and so they thought it's an acute pancreatitis. So he was referred to Manipal Hospital for further conditions. So, what are the possibilities based on history? Anybody can take it up. You still agree with the acute pancreatitis and this kind of things, or you say no, something else?
So I think this patient rightly has been diagnosed as the first diagnosis pancreatitis because he had pain and radiating to the back. So it may not be alcoholic, but it may be a gallstone pancreatitis also. So rightly, the first diagnosis we should put as acute pancreatitis. Rest other things we can think gastritis, duodenal ulcer, GERD, anything.
Yeah.
Sir, I have a different viewpoint.
Please.
Since the vomiting again contains food particles
Hmm.
and the vomiting brings about relief in pain, it also points towards a pathology, a luminal pathology, rather than an extraluminal pathology like pancreatitis.
Hmm. So what kind of luminal pathology you think in this patient?
The history is not that contributory, so broadly
No,
I will
you
think
can, you
about the
can ask me, I'll tell. You can ask me. He has an vomiting. It contains a food and food particles. It's non-bilious and any other.
gastric outlet
Yes.
obstruction would be the possibility.
Mm-hmm.
What is the cause cannot be said based on the history.
Okay. Why not just simple pancreatitis, as Mr. Saab said, because the pain is there radiating to the back. In South India, especially around Manipal area and Kerala, we see this kind of patients, young guys coming with an abdominal pain. They may not have long history without no history of alcohol, but still we have seen these patients having a
Yeah.
pancreatitis.
But it is mentioned in the history that the vomiting brings about relief in pain. That is
Yeah,
a characteristic which is usually not present in pancreatitis.
correct,
Hopefully.
correct. Yeah, I agree.
Both the components are here in this patient. One can
Yeah,
think of pancreatitis, one can think of a luminal cause, and
yes.
again, rest of the things will clarify, I think.
Yes, yes, yes. As a South Indian, I prefer definitely pancreatitis and peptic ulcer disease. I'll not rule out. And simple GRD also. Yes, sometimes these patients will have severe gastroesophageal reflux disease. So on examination, he was all right and slightly reduced breath sounds on the left side, lower zone. And he has an splenomegaly. Bowel sounds are present. Would you like to change the diagnosis now? Would you consider splenomegaly as an important part? I don't consider because splenomegaly they
Very
might
difficult.
patient might have, but it doesn't cause so much of pain
Right.
unless patient has an infarct, splenic infarct. So unlikely that splenomegaly which causes so much of pain. So I think we stick to the same diagnosis. Medgood, you would like to add something, anything?
No, sir. Same, sir. Pancreatitis, gastritis, the same diagnosis I would consider, sir.
Yeah. We have
And
seen
this
a good number of
test findings also may be in the presence of pancreatitis. That is also very difficult to exclude that the other pathology. It can be in the same line of pancreatitis.
yes, yes. So what investigations?
I think the first line of investigation beyond the again routine, the hematological and biochemical should be a abdominal ultrasound and a chest X-ray because the patient has few respiratory findings. So
Yeah.
the ultrasound might rule out a pathology, may not fully rule out, but might rule out a pathology in the gallbladder, the biliary tree, and the pancreas, and the X-ray chest will reveal the pathology in the lungs. So
Yeah.
this is my in the first attempt, I will go for these two tests. Then I'll proceed further as per the finding here.
Yeah.
Again, I have a different viewpoint, sir. Since the RFTs are normal, I would straight away like to go for a CT scan because ultrasound sometimes does not show the pancreas. The radiologist may report that it is obscured by the gases
Yeah.
and all those things.
Mm.
So a CT of the abdomen may be more contributory. Ultrasound at the best would tell you about whether it is gallstone-induced pancreatitis or a non-gallstone cause.
That is why I said that a routine screening ultrasound is mandatory because CT may not show always the presence of the gallstones. It's a scout survey. After that, we can go for this CT.
Yeah, in gallstone pancreatitis, the stones are very small. They in fact they'll have a sludge rather than a big stones.
Yeah.
So I don't think an ultrasound will be able to pick up the sludge sometimes, which is in the common bile duct. Well, sometimes it may say sludge, and patient having a bulky pancreas, we might say it's a gallstone induced pancreatitis, but very rarely that sometimes we may miss sludge in the ultrasound. Anyhow, the hemoglobin and blood investigations are within normal limits, and electrolytes and LFT is normal. And one thing that SGOT, SGPT are within normal limits, because there will be some elevation in OTPT in case of gallstone pancreatitis. However, here there's serum amylase is 117 units per liter, lipase is also 114. Would you still, I don't know why CRP is done, but lipase amylase, as per the reports, they said it's elevated. So what next? CRP, is it mandatory to have a
That's not
CRP?
mandatory. Probably as a inflammatory marker, they have taken CRP and other things. Of course, they can add also procal and other things also.
Probably
Just
done to see
inflammatory
for the
marker.
severity of
I'm
when they
totally
are kept.
against for doing a CRP unless I proved that this
Yeah.
is a pancreatitis. I'll not go for a CRP and Procal and all those things. I keep saying my children,
That is right.
I'll not pass them if you say CRP and
Sure.
other things. Well, as a part of grading, as a part of scoring, if you want to add CRP, it's fine.
But the levels of amylase and lipase are not more
Not
than
very
3
high.
times.
Yeah.
Yeah.
Not very high to say that it's definitely pancreatitis. That's what I wanted to know, the range there in their hospital. So I could not, I didn't comment on that. Anyhow, for me, it looks like a not very grossly elevated. So I definitely not think of a pancreatitis. Yes, clinically, yes. He has a typical of pain in the epigastric. We have seen good number of patients, young people coming with this kind of patient, and found to have a group pancreatitis, wherein it's a localized pancreatitis confined to head of the pancreas. So we have seen good number of cases. So ultrasound is done, and which showed pancreas appears mildly hypoechoic, suggests serum and amylase lipase correlation. So I don't know. Splenomegaly is present, multiple free floating internal leaks, some urinary tract infection is there, and mild to moderate ascites. Whoever sees these reports, ultrasound reports, I'm sure they think it's a pancreatitis. Any comments from the panelist? Okay.
Obviously, this goes in favor of pancreatitis again,
Yeah.
because there is hypoechoic and there is
Yes.
mild to moderate ascites, and
Yes.
the patient has some pulmonary symptoms. Everything goes in favor of the pancreatitis.
Yes. Yes.
Yes.
Okay. And next, what next we do? Shall we go straight away to also
So
CT scan?
the next would be a CT scan, sir.
Next would be a CT scan, probably.
And what about the X-ray? The X-ray has been done. X-ray
X-ray
chest.
chest.
Yeah. X-ray chest has been done
Yeah.
because
Yeah.
he had complained of some chest pain. So X-ray chest and abdomen has been done. So now,
So
yeah.
obviously, the left dome is elevated, sir.
Elevated.
Mhm. Yeah.
And there is
Stomach is seen below. Yeah.
stomach is seen almost entering into the thoracic cavity.
Yes.
So we can consider a possibility of eventration, sir, on the left side.
Yeah.
But I think
So
this X-ray is self-explanatory that this is a event racer. And once we see this X-ray, we will proceed further to evaluate for the event race or evaluation of a diaphragmatic hernia.
yeah. So what next? And please justify what kind of investigation you would like to CT scan, I believe. So
Yeah, CT scan.
Yeah, CT
CT
scan.
scan. CT scan.
please read. Very good.
What?
Yes, sir, the CT scan on the left side, it shows at the gastric stomach seems to have migrated up, sir.
Yeah.
The next,
Next film will clarify. Yeah.
yes, sir, definitely the stomach has migrated. There are two bubbles seen, sir. One bubble down and one bubble up. So part of the stomach has migrated up. The right side, at least, the liver is in normal position, and I think one more film, sir. I think there is some amount of whirling seen here, sir.
Yeah. Yeah.
some amount of whirling is seen here, possibly suggesting that there could be a twist also.
Yeah, correct. And there is splenomegaly also. While
Splenomegaly
this
is there.
patient
Yes,
has
splenomegaly is
splenomegaly,
there.
and there is vascularity, there are some collaterals around the stomach here.
Oh,
If you
yes,
see,
sir.
there are some collaterals, and
And Ryle's tube is not seen, sir.
Riles tube
No
is
rails,
not
sir.
seen. Right.
No, Ryle's
Yes,
tube is
Apart
not
from
seen.
stomach, some other soft tissues has also gone up.
yeah, correct. Here, probably some momentum.
Yeah. And some part of spleen has also gone up.
Yeah, and CT report is gastric valvulus with complete eventration of the left diaphragm, hemidiaphragm, likely gastric valvulus with mesenteroaxial valvulus. This patient has and moderate splenomegaly and mild ascites. So what next? We have a diagnosis, probably gastric valvulus with eventration, secondary type of gastric valvulus. Directly surgery, young man, no comorbidities.
I think we should go directly for a surgery.
Yes, yes.
Yeah.
So plan changed. Patient was diagnosed to have mesenteroaxial gastric valvulus with complete eventration. Riles tube insertion was attempted and was successful. That's great. 900 to 1000 ml of fluid was aspirated from through the Riles tube. And if there is any gastric necrosis, you see coffee ground fluid in the Riles tube. Probably that's not there. It's not mentioned. And patient was taken up for an emergency laparotomy. And urology and CTVS teams were intimated if possible requirement of intraoperative assistance. Probably because of urology, there are some looks like an infection in the in the urinary bladder. I do not know why cardiothoracic team was informed. Probably they wanted to do a thoracotomy or thoracoscopic reduction of the contents. However, Professor Rajgopal Shanai has done a surgery, he has done a laparotomy, and again, these are the findings. And eventration was identified, stomach reduced, and gastric valvulus was there, mesenteroaxial with a massive gastric dilatation, no evidence of strangulation or gangrene. Eventration of the left hemodiaphragmic involving the two-thirds of the diaphragm surface, herniation of dilated fundus of the stomach, superior pole of the spleen was there in the stomach, left kidney up to second intercostal space, splenic flexures of the colon and descending colon. If you see in the CT scan, we don't see all these findings. So there is an herniation of the stomach, spleen, left kidney, splenic flexure, and there's a moderate splenomegaly, and there are enlarged mesenteric nodes. Probably ascites is there. That's why some mesenteric nodes are enlarged. So valvulus was reduced, stomach contents were aspirated, and stomach decompressed. Hernial sac was reduced, and contents were reduced and closed. There are some adhesions between the stomach and uh, the splenic flexure. So anterior and posterior leaflets of the left diaphragm, which was formed pseudosac, closed primarily, drain placed in the pseudosac cavity and brought out through eighth intercostal space. And Professor Rajgopal Shanna will tell us whether it has done thoracotomy is also added in this patient. Gastropexy was done and greater curvature was fixed to the left anterior abdominal wall in order to prevent recurrence of the gastric valvulus, and drain also placed in the paracolic gutter. I think Rajgopal Shanai will also explain why the drain is placed in the paracolic gutter. Usually in a clean laparotomy, we don't keep any drains, neither in the stomach or in the abdomen. And abdomen is closed in the layers, and patient is doing good. And the rails to removed, and oral started, and the second day, and is doing good. So this is a pre-operative and post-operative. There's a good improvement, and the diaphragm is below, and it's closed perfectly. And the only thing is left lung little hazy. Probably he needs a good phase, post-operative and some good physiotherapy and spirometry. Biopsy of the mesenteric lymph node was done simultaneously in order to rule out since we see a good number of tuberculosis in the recent past. unnoticed tuberculosis. If you are operating for an, say, for example, Whipple's procedure, and sometimes we see a notes, we take a biopsy, it comes as a tuberculosis along with the pancreatic malignancy. Probably this patient has an ascites. That's why treating surgeon has a doubt and did a biopsy which showed a reactive lymphadenitis. And post-operatively is comfortable, doing good, and reviewed after 3 months and is doing good. Some basic literature review, some gastric valvulus, and as you know, stomach has an attachments with the liver, spleen, colon, and diaphragm. So gastrohepatic ligament, gastrosplenic, choric ligament, and this helps the stomach in a position. Otherwise, the valvulus is most common. And as you know, there are two kinds of valvulus. One is organoaxial and mesenteroaxial, and which occurs acutely, needs an acute surgery. So in order to, there are two types of primary versus secondary. Primary is basically the abnormalities in the gastric ligaments and failure of the gastric fixation. Secondary is due to some other problems, like this patient has an diaphragmatic eventration, and even previous patient has an also paraesophageal hernia. These are the secondary causes of gastric valvulus. And failure to insert an Riles tube, one of the Bouchard's triad, sudden onset of pain and recurrent retching with not able to pass NG tube. They're all the symptoms suggestive of a gastric valvulus. And plain film is suggestive, and similarly, CT scan also. It is gastric valvulus, is a surgical emergency. And if the Riles tube doesn't go, one should think of an gastric valvulus and operate on these patients. So that's all about the two cases, and one spotter from my side, and Professor Shanai also can contribute. Sir, Shanai, sir, I'll just show another pictures. Please, for the panelist,
Yeah. Oh,
for
nice.
the panelist, I request you to read CT and then give your diagnosis. It's okay. I've done a mistake.
Yeah.
So there is a mass-like lesion here. You can see here.
Yeah.
So here and here in the chest. So this is an old, long back I had operated. Suddenly I remembered yesterday after seeing Professor Sanai's photographs. This is, can see this big mass in the right side of the chest. This is a big mass in the right side of the chest. And see, you can see this angiogram also, CT angiogram. This is a splenic artery going like that. So, and a splenic vein going like that. So, and there's no spleen here. So that was a
Situs.
spleen. And then that was a spleen in the chest.
Huh.
Oh, I see. That's
So
a
this is
spleen
the
in
whole
the
thing.
chest.
Yeah, splenic artery and going there. The spleen and patient had child, as a patient had, it's in a congenital intrathoracic spleen.
Hmm.
Very, very rarely seen. I do not know how it has gone. Some congenital abnormalities, very few reports. I don't have an operative findings, operative pictures. I tried to get operative pictures. I didn't get. Otherwise, I would have shown. So the entire spleen was in the right chest. So I could not bring it because a lot of adhesions to the spleen in the chest as well as in the abdomen. So I have to ligate the splenic artery and then did a splenectomy in this patient. So I'll find out if there are any pictures, operative pictures in this patient. Very, very rare. I've seen only one case, congenital, totally patient did not have any history of trauma or any surgery. I don't know how spleen has gone there and stuck in the right side of the chest. So thank you. Thank you very much for giving me this opportunity. Thank you, sir.
Thank
Rajgopal.
you. Yeah. Thank you, sir. I have there are a few questions. First, I will tell whatever collected. Firstly, the in um, presence of the volvulus, is it possible to decompress? I think you have made very clear. I think it's a partial volvulus. You should be able to decompress. Correct?
Yes,
Very
partial
much.
valvulus. If you are not able to pass the Riles tube and it's not going into the stomach, it means it's in a complete valvulus.
Usually in the other mesenteric axial, many times it is 180 degree. So sometimes it is possible, but if it passes, you are lucky.
Yes. Yes.
So
So
can
there is
we
one more.
make use of needle aspiration or something to help in decompressing? Of course, it will violate the clean field, but then will it be useful, sir? Like putting in a wide bore needle and aspirating and reducing the gastric contents?
You mean on the operation table or pre-operative?
No, on the tables, on the table.
On the
During
table,
surgery.
it's not necessary. Once you derotate it, there's no need. You automatically get decompressed. And we can pass the rails tube and decompress. I think one should not put any needle into any lumen and to decompress. We used to do colonic, but long time back we don't do now. We have
Just a
learned.
policy that when we are derotating, please
Yeah.
pass the rails tube beyond that,
Correct.
so that
Yeah.
automatically it will be decompressed. That is a part of the surgery.
Yes. Yes.
Okay, sir, one or two things from my side. That is, both cases have been chosen so as to make the interesting part of it is that how they come carrying actually chest X-ray to the hospital. The
Yes.
presentation is like, they come with the X-ray like that. So this is how in fact, with the simple X-rays, one can make a diagnosis. Our Dr. Naz, our chairman and surgeon from hospital, she has, after looking at the X-ray itself, she gave a diagnosis of recurrent gastric volvulus with the history and that X-ray. First case in the YouTube. I'm just telling the comments from the YouTube. That lady, in that I never thought of thoracoscopy or something, because it's right side, and I thought it should be you should be able to manage that. That is about the first case. Weight reduction is the main thing in that lady, because she was very obese, hypertension, diabetes. It was also taken as something like a semi-emergency situation. And coming to this boy actually we did during the COVID time. That if you see, the RT-PCR was done in that, that one sentence was there.
Yeah.
This particular case. In fact, we call the urology help because if you see, the kidney is in the CT itself is very highly placed, very high.
Yeah.
Even though it was, if you see that CT image, already we knew that kidney was inside the thorax. So, and some air shadow which we were talking, something about that was the colon actually. So,
okay.
Yeah, and the patient was a young boy, but since the diaphragm line was very nicely seen, we thought it's definitely ventration. That's how we landed. So that was also during COVID time emergency we did. So we thought in case it was night, I think sometimes. So if we need any help, that is the reason we involved in an institution, institutional some policies and guidelines are there. So that's how we involved. But as somebody has asked in the YouTube that any role for ICD, intercostal tube, on that second case. That
Doing a
second
pneumothorax.
case.
Yeah, second case. I think it's better because the diaphragm is thinned out. Invariably end up opening into that, and some pneumothorax will be there. It's better put a ICD and then come out.
If the chest has not been opened at all, what is the need of a ICD?
Correct. So that's why what happened is, these are the anecdotal cases, because we don't have much experience in volumes to talk about this. Where after reduction, there's a pseudo sac like thing there.
Yeah.
So the suggestion was that some seroma or some fluid may collect in that. Actually, pleura was not opened in this case. Clear?
Yeah.
So we put a tube into that pseudo sac like thing under vision from below, but putting it almost like coming out from the lower rib spaces. It is not intercostal tube, but it will drain that cavity.
The only thing is, what about putting the mesh?
Sir?
Putting a mesh.
No, in that we have not done the mesh.
In this patient, particularly in the COVID era, mesh was avoided. And dissection might have been very difficult here also.
So, I know. But somehow, the both cases, we were able to get a good approximation, as you rightly put it, without tension. So that is the one thing which we did. So anyway, that is the purpose. These are some of the comments in this one, in the YouTube. So
Yes,
any other panelists? Yeah,
yes,
please.
Sir. In both cases, sir, especially in diaphragmatic hernia, The diaphragm was so thinned out, so we put IPOM mesh, sir.
That's what I'm telling, sir.
Yeah.
Mm.
Both in thoracoscopically as well as the laparoscopically, we put up IPOM mesh. That is one thing I want to express. And one question to Dr. Birappa, sir. You showed one congenital intrathoracic spleen.
Yeah,
The
yeah,
mass
yeah.
was seen in the right thorax.
Yeah.
Right
Correct.
thorax. Yes. Yes, it was in the right thorax. I don't know. I'm not able to explain. It's in a
That is,
congenital.
I asked, was it a situs inversus?
No, no,
See,
it was not situs inversus.
I
It was
know.
not situs inversus. No, not at all. You can
Peter
see the
got
right liver in the
correct.
right side. So even you can see the splenic arteries going from the supramesenteric artery, from the celiac trunk. It's going from the supramesenteric artery into the right chest. So it's in a congenital intrathoracic spleen.
You can add wandering spleen also, sir.
Yeah.
We have seen a warning spleen in the
Wandering
pelvis.
spleens we have seen. We have seen in the pelvis and the other thing. But intrathoracic spleen, that is the first claim.
Okay.
I tried to pull it into the stomach, but it was not. Even I did a thoracotomy, but I could not bring because of lot of adhesions, and spleen was stuck there and capsule tears and started bleeding. So I had to do an splenectomy.
You can stop sharing, sir.
Yeah.
Yes, sir.
Okay. So thank you, sir. Thank you
Actually,
very much.
we have not done the thoracoscopy or laparoscopy in this particular situation of a young boy. But the thing is, I was talking to some of the experts who are able to even tell that the whole thing, even kidney and the ureter, everything is possible to get it down into the retroperitoneum through the approaches.
Yeah.
So that was
the role of thoracotomy or thoracoscopy comes in a case of a short esophagus, congenital short esophagus, or fibrosis of the short esophagus because of the fibrosis. Then we need to lengthen the esophagus and then do either like Colles gastroplasty or lengthening mobilization of the esophagus and then do a fundoplication in order to prevent the recurrence and other things. But it will be very difficult. Invariably, we end up injuring the vagus nerve and cause some problems. So we do not have much experience in mobilizing the entire esophagus.
I also want to just say this 3 years, 4 years over now for this. I have a follow-up of this patient every year. But the issue is he still has the kidney inside his thorax.
Oh.
That's what the point which I was trying to tell was that if it should have been, this was happened during the COVID time, and I said already it was done as an emergency, but he's already economically coming from him. So I said, this is what you should keep it in mind.
Sir, how come is it that it is in the thorax? That means there is a hernia again.
No, later I have not done.
Okay.
I have not done the what is that? So retroperitoneum also it has been slided up, sir.
Right.
See, what we opened, we reduced. Correct. The whole complex.
Excellent case discussions. We have shot already by 17 minutes. We wrote short the time. Excellent discussion and excellent moderation by learned academician, senior teacher Dr. N. Veerappa. I also good discussion from all the panelists. Now I request our Honorable Treasurer Dr. Madhumita Mukhopadhyay to propose vote of thanks.
Thank you, Dr. Divakar. My sincere thanks to our President, Dr. Maruthu Pandian, our Vice President, Dr. Barute, and our past President, Dr. Proval Nyugi, for all your valuable contributions. Thanks to our academic advisor, Dr. Santosh Abraham, and our academic director, Dr. Shenoy, for putting up this whole program together. Thanks to Dr. Veerappa for a very excellent moderation. Thanks to our speakers, Dr. Mishra, Dr. Malhotra, Dr. Ankur, and Dr. Midgood. This is a very good discussion. Thank you all so much. Thanks to all our viewers. Thanks to Dr. Gaddi Divakar, our secretary, a very hardworking secretary.
Yes.
Thanks to all of you all. Long live ASI. Good night.
Thank you. Good night.
Good night.
One
everyone.
request from my side is we have a lot of case capsules. I might useful in contributing a lot of case capsules to Association of Surgeons of India with the permission of the chairpersons, and president and director of academics, Professor Rajgopal Shanai.
Please,
I may not be.
welcome, sir.
Yes, sir. I have a lot of case capsules since
Yes,
I have very lot of case capsules. I can say
fantastic.
that I have plenty of case capsules. I'll be useful in contributing those to AS.
Definitely. Very
Thank you,
good.
sir.
Thank you, sir.
Yes,
Thank
Utilize
you.
yes.
your
Good night,
Yes,
sir.
sir.
Good night,
Good
everyone.
Yes.
Good night.
Thank you very much. Thank you very
Thank
much.
you.